Welcome to Path to Success. Today my topic of presentation is Odontogenic Keratocyst. I am Dr. Soma Susan Verghese, Department of Oral and Maxillofacial Pathology, Epithelial Dental College. So let me define cyst first. So cyst is defined by Kramer et al. As a pathological cavity having fluid, semi-fluid or gaseous content that are not created by accumulation of pus, frequently but not always is lined by epithelium. So true cyst is a cyst which has an epithelial lining, and a pseudocyst is a cyst which doesn't have an epithelial lining. So before discussing in detail about odontogenic keratocyst, I would like to give you a classification of Joe cyst. So this classification is taken from the textbook Shear edition 9. So under the category of cyst of oral and maxillofacial region. So I am discussing on Joe cyst here, the classification of Joe cyst. So he has classified cysts into epithelial lined cyst and non-epithelial lined cyst. So under epithelial lined cyst, there is a developmental cyst and inflammatory cyst. So under developmental, there is odontogenic and non-odontogenic. So first we are discussing the developmental category of odontogenic cyst, wherein there is dentigerous cyst, eruption cyst, odontogenic keratocyst, gingival cyst of newborn, gingival cyst of adult, lateral periodontal cyst, glandular odontogenic cyst, botryoid odontogenic cyst, and calcifying epithelial odontogenic cyst. So under non-odontogenic cyst, there is mid-palatine raphe cyst of infants, nasopalatine duct cyst, and nasolabial cyst. Then inflammatory category. So you all know that there is radicular cyst, is otherwise called as periapical cyst, then residual cyst, periodontal cyst and juvenile periodontal cyst, and inflammatory collateral cyst. So next is the non-epithelial lined cyst, which include solitary bond cyst, aneurysmal bond cyst, and mucous extravasation cyst. These three cysts don't have epithelial lining, so they are otherwise called as pseudocyst. And cyst of maxillary antrum, which include mucosal retention cyst and post-operative maxillary cyst. It is otherwise called as surgical ciliated cyst of maxillary sinus. Then coming to the topic of discussion, that is the odontogenic keratocyst. This odontogenic keratocyst is otherwise called as keratocystic odontogenic tumor. So in 2005, WHO World Health Organization for the classification of odontogenic tumors and cysts has put this cyst under tumor category, and it is said that this is a benign cystic neoplasm. Recently in 2017 WHO classification, this cyst is again recategorized into odontogenic cyst. So let us see what are the characteristics and clinical features of this particular cyst. So odontogenic keratocyst arises from the remnants of dental lamina and basal cells of oral epithelium. It is more aggressive than radicular cyst and dentigerous cyst. It is also considered as a benign cystic neoplasm than a cyst because of its local aggressive behavior. Okay, it has a locally aggressive infiltrative behavior and high recurrence rate. And there is a condition called as nevoid basal cell carcinoma syndrome, where there is a mutation of PATH gene happening in chromosome 9 with multiple occluses in quadrants of the jaw. Okay, we will be discussing in detail about nevoid basal cell carcinoma syndrome after discussion of odontogenic keratocyst. So recently WHO has classified odontogenic keratocyst as a cyst only. So the name keratocystic odontogenic tumor is no longer existing for the cyst from the 2017 classification of odontogenic cyst and tumors. Okay. So this is the clinical picture of odontogenic keratocyst. We can see a growth extending from the premolar area to the molar area. Okay, so it is extending in the antero-posterior direction. So occlusy usually enlarges in the antero-posterior direction of the jaw rather than expanding in buccolingual direction. Okay. So majority of cases of OKC occur in second and third decade of life with slight male predilection. 60 to 80% occur in posterior body and ascending ramus, third molar area, followed by first and second molar area and then the anterior mandibular region. So 60 to 80% of the cases occurs in the posterior body and ascending ramus of the mandible. So this is the main site of occurrence of OKC. This is a radiograph of OKC growing in antero-posterior direction. It is a multilocular radiolucency. We can see septa false septal defect of bone here, giving a multilocular radiolucency. So, large cyst, if OKC has grown to enormous size, it could be associated with pain and paresthesia of lip, swelling, drainage, and other neurological manifestation. In maxilla, the most common site is the third molar area, followed by the cuspid region. Since OKC is locally aggressive in nature, it has a tendency to resorb the root of adjacent normal teeth, and the cyst can even displace the neurovascular bundle also. There is another variant called as peripheral odontogenic keratocyst. So this peripheral odontogenic keratocyst arises from the basal cells of oral epithelium, and its usual presentation is in gum, buccal mucosa, tissues of buccal mucosa, and deep lateral facial regions. So these are the areas where the peripheral odontogenic keratocysts are evident. Aspirate of the cyst contains juicy material suggestive of keratin. Sometimes the aspirate may also contain straw-colored material. Coming to the radiographic features of OKC. OKC shows unilocular or multilocular radiolucency, and scalp borders are also found representing variations in the growth pattern of cyst. When cyst is associated with impacted tooth, it mimics a dentatorous cyst. Usually, movement of adjacent teeth and resorption of adjacent teeth are also evident. So this particular slide, if you see, you can see a picture wherein which the OKC has occurred in relation to the crown of an unerupted teeth. So this is an envelopment variant of OKC, and in this particular picture we can see OKC growing in anteroposterior direction. It's a multilocular radiolucency, and here OKC is trying to resorb the root of the adjacent teeth. And in this particular picture again a unilocular radiolucency can be seen, and it is even enveloping the crown of the adjacent teeth. And here an anteroposterior growth with the multilocular radiolucency present. So these are all the various radiographic representation of OKC. It can be unilocular, multilocular, it could have a scalloped margin, or can be an envelopmental which occupies the crown of an area of the crown, surround the crown of an unerupted teeth, or sometimes replacemental where it occupies the space of a teeth. Okay, and or else it can even occur in between two teeth. Okay, so these are the various radiographic representations of OKC. So coming to the histopathological feature, it has a lining of parakeratinized stratified squamous epithelium of about 6 to 8 cell layer thickness, and the basal cells are columnar and are arranged in palisading manner. Palisading means they are arranged in parallel to each other, giving a picket fence appearance, or it is otherwise called as tombstone pattern. The surface of the epithelium is corrugated and parakeratotic, and the epithelium usually gets separated from the connective tissue because the epithelium secretes collagenase enzyme which makes it separated from the connective tissue. So this is the lining. We can see the basal cells in a palisading pattern. See, all these cells are arranged parallel to each other and about 6 to 8 layer thickness, and the surface of the epithelium is corrugated and it is parakeratinized. And some areas we can see the epithelium getting separated from the connective tissue. Okay, so epithelium has a high tendency to get separated from the connective tissue. and the lumen usually contains keratin. Okay, so these are the histopathological features of parakeratinized odontogenic keratocyst. Previously, there's another category of odontogenic keratocyst which is called as orthokeratinized odontogenic keratocyst. But now it is not classified under odontogenic keratocyst. It is another variant of odontogenic cyst. Okay. So, or orthokeratinized case is not a odontogenic keratocyst now. And the cyst has also usually shows a satellite cyst or daughter cyst within the cyst capsule, uh, which is again a reason for the high recurrence rate of OKC. Okay, so OKC usually shows a satellite cyst in its capsule. Then discussing on the OKC growth and expansion. So the cyst has an unremitting growth pattern. Here actually this epithelial lining at the connective tissue capsule of the cyst is proliferating, which results in the growth of the cyst. It is not the osmotic pressure or anything which results in the growth of the cyst. It is a proliferation of the epithelium and the connective tissue. Okay, it can proliferate in local groups. This or as a plaque-like proliferations. These can result even in scalloped margin formation at the boundary of the cyst. And even the epithelium and the connective tissue can even interact with each other. They are dependent to each other. In previous studies from the textbook, it was found that textbook Shear, it was found that if the capsule is not there, the epithelium cannot proliferate. So they are dependent to each other. Okay. And what are the reasons for the high recurrence rate? So according to Shear, the high recurrence rate is about more than 30% for OKC, and it occurs highest if the OKC occurs in the ankle and ascending ramus of the mandible, and a fragile cyst wall make it difficult to be removed in one piece. So if the cyst is not removed correctly, again it can recur. The scalloped margin of the bone due to the aggressiveness of the cyst is another reason for its recurrence. The presence of satellite cyst in the capsule and the intrinsic growth potential of the cyst wall and the lining also are the reasons for the recurrence. So these are the reasons for the recurrence of OKC. From treatment side, marsupialization or enucleation of the cyst should be done. So now we are discussing on nevoid basal cell carcinoma syndrome or Gorlin and Goat syndrome. So it is a condition or a syndrome where multiple OKCs can be seen. Even 4 quadrants show OKC, okay, and high recurrence rate. So it is an autosomal dominant inherited condition due to the mutation of PTCH gene or PATH gene on chromosome 9q22. So what are the features of basal cell nevoid carcinoma syndrome? So the first one is cutaneous anomalies, so the skin manifestations. So basal cell carcinomas, benign dermoid cyst, palmar plantar keratosis, palmar pitting, and dermal calcinosis. So this is a picture of basal cell carcinoma. You can see multiple areas of lesions all over the face and multiple OKCs. So we can see OKCs on both the quadrants of the jaw. Here you can see a well-defined radiolucency, here a multilocular radiolucency can be seen. So multiple OKCs are present. Other features are intracranial calcification, bifoot rib and vertebral abnormalities, bossing of frontal and temporal bone, eyes appear widely separated, that is called as hypertelorism, congenital blindness and internal strabismus. So this is a bifoot rib. It's again a key anomaly of nevoid basal cell carcinoma syndrome. Other features are mental retardation, calcification of falx cerebri, dural calcification, hypogonadism in males and ovarian tumors in females. So coming to the conclusion of this presentation, odontogenic keratocyst is a locally aggressive cyst. It has a clinical aggressive behavior and it has high recurrence rate. The high recurrence rate is due to its biological behavior. Okay, its biological characteristics are reasons for the high recurrence rate of the cyst. If associated with nevoid basal cell carcinoma syndrome, multiple occlusions can be seen in Jews. Okay, so thank you for listening to my presentation, and these are my references. I have referred from the textbook Shear, Schaefer's, Neville, and few articles. Thank you.